very well-known pediatric hemato-oncologist in US, and we can have a very prompt start. And again, it's my pleasure to introduce a world figure very well known in the field of hematopathology, Dr. Sharif Ibrahim, a dear friend and an expert. And I myself learned a lot from his expertise in the field of hematopathology. Please, Dr. Sharif, we can start.
Thank you, Dr. Haddad. First, I want to thank the organizers, particularly my dear friend, Dr. Alfie, for great effort, and our colleagues at Ain Shams University. I am grateful for the invitation, and it's wonderful, especially in these challenging times, to see your faces and to be able to talk with you. I'm going to take a second also to speak about the title. The title in the brochure says the use of flow cytometry in diagnosis of lymphoma. Dr. Alfie and Dr. Ashraf Mohammed and I discussed it and figured out that's too narrow. We expanded it a little bit to diagnosis of non-Hodgkin lymphoma in adolescents and young adults. We'll talk about flow a little bit, but we'll also talk about one important subject, which is diagnostic workup for lymphoma for effective and efficient and cost-conscious diagnosis. Okay. So that slide confirms what we know, that in pediatrics, non-Hodgkin lymphoma is not a very common disease. Most cases in very young age, pediatrics of non-Hodgkin lymphoma are Burkitt's lymphoma, followed by lymphoblastic lymphoma, while diffuse large B-cell lymphoma is sort of rare, and the same for ALCL. In adolescent, the trend changes a little bit, and diffuse large cell lymphoma becomes the most common lymphoma, Burkitt's second, and then after that, ALCL and lymphoblastic lymphoma. In young adults, that changes completely, and now follicular lymphoma is the most common. I'm going to focus on that group. That's this group of patients is what I see in my practice, somewhere between 16 and 21, 22. I'm going to cover for the first few minutes, how do we do diagnostic workup for lymphoma that's efficient, effective, and cost-conscious. It's important to go over that because I do see quite a few cases, not just from Egypt, from the Middle East, and from other countries, and quite often that the workup is incomplete, the sample itself is not the best, preparation is not great, and that's really where you start. You have to have a decent sample, you have to use all your techniques to reach the right conclusion, and then you have to effectively communicate that to the oncologist. So what types of biopsies we need? Traditionally, we just use excisional biopsy, and that's still the preferred method. However, recently we moved away a little bit from that. Our interventional radiologists became very good in doing needle core biopsy, and if I need an aspiration, these materials are great and fast to get. However, they are limited and limiting. For example, needle core biopsy, we do a lot of that in US. We moved away to great deal from excisional, and unfortunately, that creates a lot of false negative cases. Needle core biopsy, you cannot diagnose lymphoma if the lymph node is only partially involved. If you go into the area that's not involved, you're going to miss it for sure. Certain lymphomas, for example, Hodgkin lymphoma, it's hard in the needle core biopsy. The particular subtype of nodular lymphocytic predominant Hodgkin lymphoma, it's almost impossible to diagnose on needle core biopsy. T-cell lymphomas are very hard, even with excisional biopsy. Now with needle core biopsy, it's really limited, and false negative is common. Fine needle aspiration is great for some cases. However, without the flow, it's very limited. Sometimes the diagnosis you can find in bone marrow and peripheral blood during staging. And quite often in CNS lymphoma, CSF is important, or if you have lymphomas that involve in the CSF, the CNS, then CSF is important. However, flow is also essential here. Sometimes we get lymphoma of the GI or skin, and that's the biopsies we get. So why excisional biopsy? Excisional biopsy gives you enough tissue to divide. And first piece of it will go into formalin for routine histology, and that's still the gold standard. It's very cheap. It is really the morphology is still a king to my mind. That's how you look at the entire architecture, and you'll be able to tell from the architecture what kind of lymphoma we're talking about, and then that will guide the additional workup as far as the immunohistochemistry and facial things like that. Flow cytometry, lately flow became incredibly effective, and we use it in all cases. So if you have a piece of tissue, first piece goes for routine histology and in paraffin. The second goes in RPMI for flow cytometry, and a smaller piece in RPMI for FISH. And if you are in academia and you have extra tissue, actually it's fantastic if you can freeze a piece and keep it in minus 20 or 70 for the future. It comes in handy when you have a new drug or a new trial in which you want to have tissue to look at. That's very helpful. So, comprehensive immunophenotype. Once you get your H&E section, morphology is great. It tells you it's lymphoma, but it doesn't tell you if it's a B or T and what subtype. Then you need to use immunohistochemistry, and you have to have enough panel of immunohistochemistry. How do we decide on that? I'm going to go back about 20 years ago. In the late 90s, we recognized that diffuse large cell lymphoma is a wastebasket in which we have a lot of lymphomas that morphologically they may look alike, and however, they are immunophenotypically different, and the pathology is different, and they don't respond the same for the same kind of therapy. So it's clearly this is a mixed bag. To separate that, the US, there were several labs working on a challenge grant, basically trying to divide the diffuse large B-cell lymphoma with the idea we can have better diagnosis, better therapy, and better prognosis. That study was published in Nature, loosed out from the NIH. He looked at tons of cases and actually examined 350,000 genes using gene expression profiling. And that gene expression profiling was able to divide cases to simplify it into two subtypes. Half the cases, they have a gene expression profile that looks like germinal center of the lymph node, and we call those germinal center-like diffuse large B-cell lymphoma. The other half, they have gene expression profile that's different, looks like both germinal center or non-germinal center or activated B-cell type, and it was called non-germinal center. And in the literature, you're gonna see the word activated B-cell subtype sometimes. So we have two subtypes of lymphoma. Okay, can that help us now in diagnose and treat lymphoma? I don't think so. I don't have gene expression profiling in my lab. And if I do, it's very expensive, it'll take a long time, and that defeats the purpose. So how do we translate that to a better way that can serve our patients? In 2005, University of Nebraska came up with a very simple model. It's called HANDS model. It's an algorithm. Basically, you stain diffuse large cell lymphomas with three markers, CD10, BCL6, MUM1. You stain with CD10 positive. If the lymphoma is positive, then it's the germinal center type. If it's negative, then you stain with BCL6. If BCL6 is negative, it's a non-germinal center type. However, if BCL6 is positive, you go to MUM1. MUM1 positive is a non-germinal center. If MUM1 is negative, it's a germinal center type lymphoma. It's really simple algorithm. If you do it 2-3 times, you will memorize at the back of your hand, and it's very effective. However, there were some criticism that that model is simplistic and doesn't cover everything. So several other models were introduced, looking at other markers like FOXP1 and BCL2. However, in conclusion, it turned out that the simple model actually worked the best. We added to it BCL2 because it turned out to be an independent prognostic marker. How about flow cytometry in diagnosis of lymphoma? Flow is similar to IHC. However, it has several major advantages. Speed. You can do a flow within an hour. If you are in academia and once you remove the excisional biopsies, it goes to the lab, I produce reports within an hour. And especially if you have an acute leukemia case or you have a Burkitt's lymphoma, you have a very sick patient, it is very, very fast. The newer flow machines, it has capacity to do a lot of cells in a very fast with a lot of antibodies. So it has speed. It's also very precise. You can look at the one cell from 15 different angles. You have 15 antibodies in one tube. You can classify that cell so many ways. And that's really very helpful also when you have small material. If you're looking at CSF, which is very hard to do by cytology alone, you can do that by flow really very effectively. And if you're looking at FNA, again, flow is incredibly helpful. So here, just to make the point, this is a histogram from my old flow machine. I used to have 2 colors when I started 25 years ago or so, and then 4, and then 8. And my techs used to run that in the lab, and they gave me pictures like that, histograms. Now I don't get histograms. Now it became incredibly advanced. Instead of 2, 4, and 8, we have 15 colors, and we have incredible software. I get a file on my computer, and that's what I get. And I can gate on any cell. I can follow them. I can color them differently, and I can count them up to 1 cell per 10,000. Every 10,000, you have 1 abnormal cells, you can detect it. And so this is incredible advances. So how do we use that to diagnose lymphoma nowadays? Let's go over cases. AM is 17-year-old male with left neck mass who got an excisional biopsy, 2 by 2 centimeter, submitted to us in RPMR. We divided it, took a piece for routine histology and formalin, and a piece for the flow lab, and another piece for FISH study. Flow cytometry. That's within the hour we have results. This histogram looks at site scatter, complexity of cells versus CD45. We know lymphocytes sit in that gate. They are bright CD45, and in that case, you look, 92% of the cells are CD45 positive. Few cells, granulocytes sit over here, 3%, probably blood contamination, and few dead cells. So you have 92% of the cells viable, and this is a very good sample. Then the next histogram, you look at CD19, which is the B cell marker, versus forward scatter, which tells the size. The size of these blue cells, these are normal T cells. The CD19 positive B cells, very few normal B cells sitting in the same size like the T cells, but the rest of the B cells are large, larger, and larger. Some of the B cells are at the 900 or 800, 2 to 3 times as big as the T cell. So the conclusion here, we have a lot of B cells that are really large. In the next question, are these cells neoplastic? Are they clonal? You go to that histogram. 98% of the cells are lambda restricted versus kappa. So now I have large cell lymphoma that's lambda restricted. And the next question is, are these cells coming out of germinal center or non-germinal center? CD10 is a germinal center marker. It's negative here, only 0.07. So the cells are large cells, they're lymphoma, non-germinal center, very likely. That's not 100% here. So the next question is, okay, what do we do with the histology? And this is a touch imprint. You can do that's very cheap. You touch your tissue on the slide and then you stain it. And here you can see a few small size lymphocytes, many large cells, and H&E sections. Large cells are big, prominent nucleoli. That's consistent with large cell lymphoma. Some mitotic activities here. You can see chromosomes dividing. And then the stains, CD20, all the cells are CD20 positive. So it's a B cell lymphoma, which you knew from flow. But now we also have Ki67 that tells us this is probably an aggressive lymphoma. Anything above 50% is higher grade. Next battery of antibodies, CD10, which we knew from the flow was negative. BCL6 is another germinal center marker, is also negative. So that lymphoma is not a germinal center. It's negative for 10 and BCL6. However, it's positive for MUM1 that confirms it is non-germinal center or activated B cell subtype. And BCL2 is positive, which is independent for prognostic marker, at least in adults. The next question, do we know the mechanism? What kind of translocation or molecular changes are there? You do these 3 markers all the time. One's BCL2 and IgH. It looks like we have several BCL2 and several IgH that tells us they're probably hyperdiploidy. The same with MYC. We have 3 to 4 dots in here, the same with BCL6. So we have hyperdiploidy, which is common in large cell lymphomas. And the final here, this is a diffuse large B-cell lymphoma of non-germinal center subtype, or ABC, positive FISH for hyperdiploidy, no evidence of double or triple hit lymphoma. This staging Maru was done the day after, looks good, no evidence of lymphoma, CD20 picked up only rare single cells. So that basically says that the bone marrow is not involved. Next case, MD, is an adolescent female with large liver mass and ascites. Samples we got liver needle core biopsy and ascites fluid. Flow cytometry, which we done right away, it shows that the cells, majority of the cells are CD20 positive B cells that are also CD10 positive. And these cells are CABA restricted. That confirms a lymphoma diagnosis. CD10 positive, that means it's coming out of the germinal center. The day after, here's the ascites fluid. We did centrifuge and we did smear. And you can see here intermediate size lymphocytes. They're not that large, with a lot of dead cells in the background, a lot of apoptotic bodies. And needle core biopsy of the liver, you don't see liver tissue here. It's completely replaced by diffuse lymphocytic infiltrate composed of these intermediate size lymphocytes. We did stains. This is CD20. All the cells are 20 positive, but they're also positive for CD10, BCL6. That confirms germinal center. We also did MOM1 and BCL2, and both are negative. We added to that MYC for MYC expression by immunohistochemistry, which is positive in that case. We looked at Ki67, which is 100% in that case. This combination together is very good for Burkitt's lymphoma. So we ran a FISH, and the FISH confirmed normal IGH2, normal BCL2, normal BCL6, and MYC rearranged. So putting that together, we're comfortable 100% that this is a classic Burkitt lymphoma, positive for MYC rearrangement, but also we did EBER stain, EBV turned out to be positive also. Here is the third case. GW is a young male with left parotid mass. The touch imprint, very impressive. This intermediate size lymphocyte. And here you can see that bluish cytoplasm with vacuoles, looks like Burkitt. However, you also have these large cells with single prominent nucleoli, which is not common in Burkitt. Burkitt is usually intermediate lymphocyte. This is more of a large cell lymphoma. So you have a heterogeneous population that looks small and large. The flow cytometry picked up CD10 and CD20 positive lymphoma. Then they're all CABA restricted. Immunohistochemical stain, the cells are positive for CD10 and BCL6, germinal center, CD20. Additional stain, MYC expression, which we said that was in Burkitt's, but you can get MYC expression in diffuse large B-cell lymphoma. Ki67, 80%, BCL2 positive. You don't see BCL2 expression in Burkitt's. The FISH study was impressive for two things. One, you have 1418 translocation, which is common in follicular lymphoma, but also in large cell lymphoma. But in addition to that, you have MYC rearrangement also. So you have what's called double hit lymphoma. So if you put the data together, this is the high-grade B-cell lymphoma with features intermediate between diffuse large B-cell lymphoma and Burkitt's lymphoma. This is a definition in the current WHO classification 2016. Positive FISH for 1418 and MYC rearrangement, negative EBER FISH. I'm going to switch gear now for different kind of lymphoma. 19-year-old young female with large inguinal lymph node. We got a biopsy. The flow showed that very few B cells, CD19 positive. The vast majority of the cells are T cells, CD3 positive. And if you do look at CABA versus lambda, cells are divided, CABA and lambda, so it's polyclonal. If you look at the T cells, the vast majority of the cells are CD4 positive, 96% versus 1.7 CD8. They are CD26 positive, which is not important here, but this is important. So that 4 positive, they are very bright for CD30. Some of the cells are small and large and brighter And here you have multinucleated large cells that are very strongly positive for CD30. The cells are also positive for CD25. Morphology, touch and print, multinucleated large cells, binucleated, very prominent nucleoli, the H&E sections. You can see some multinucleated in the background, some eosinophils. This is characteristic of anaplastic large cell lymphoma. The immunohistochemical stains confirm that the cells are positive for 2, 3, 4, but they're also positive for CD30 and ALK. FISH performed on the tissue sections. It doesn't look great because tissue sections, but it shows derivative of chromosome 5 here, chromosome 2 here. Together, the ALK, if you have green and red, it shows yellow, and that's the translocation. So this is ALK positive anaplastic large B-cell lymphoma.
Professor Sharif, we have, okay, you are going to the summary. Thank you.
Okay, we have go to the summary. So the summary, diagnosis and classification of lymphoma is a complex multimodality process that requires communication between oncologists and the hematopathologist. Excisional biopsy is the preferred type of sample. Adequate battery of antibodies by IHC and flow cytometry are needed for classification of lymphoma. FISH studies are very helpful for confirmation and for giving us some insights into the molecular pathology. Case review in multidisciplinary conference is strongly recommended in all cases of lymphoma the first time we diagnose. That's the end of my slides. Thank you very much.
Thank you very much, Dr. Sharif, for a very elegant, simple presentation. We're having questions that we are going to keep till the end of the session as per the original schedule. And now it's again my pleasure to introduce one of the bone marrow transplanters, a colleague, a friend, Mahmoud Hamad, who I'm privileged to work with, and he's going to talk about the management of relapsed refractory non-Hodgkin lymphoma. Please, Dr. Mahmoud.
Dr. Hamad, please unmute your microphone.
Sorry. I would like to thank the organizers, Dr. Ala Al-Haddad and Dr. Mohsen Al-Alfi, for giving me the privilege to be with you today in this valuable meeting. My talk will be about the management of relapsed and refractory Burkitt lymphoma in children. The talk will cover the histopathological subtypes of pediatric non-Hodgkin lymphoma, and of course, after the previous presentation, it will be just a simple note. The treatment strata of pediatric mature B-cell non-Hodgkin lymphoma, relapse patterns of Burkitt lymphoma, and the salvage chemotherapy, and the difference in outcome in autologous and allogeneic transplant in refractory and relapsing Burkitt lymphoma. As just previously mentioned, that Burkitt's lymphoma is the most common subtype of non-Hodgkin lymphoma in age group below 14 years of age, constituting around 38% of patients, and in older age group, it comes third, preceded by the diffuse large B-cell and lymphoplastic lymphoma. 60% of cases present with advanced stage 3 and stage 4. According to the WHO classification, mature B-cell non-Hodgkin lymphoma includes the Burkitt's lymphoma, the Burkitt's light lymphoma with 11q aberration, which is provisional, the large B-cell lymphoma with IRF4 rearrangement, which is also still provisional, the diffuse large B-cell lymphoma, and the primary mediastinal large B-cell lymphoma. The most two common risk group stratifications used in pediatric groups is the Berlin-Frankfurt-Munster and the French-American-British classification. The French-American-British classification is more widely used in our region, which classifies patients from low risk to higher risk group, where group A are resected stage 1 and abdominal disease completely resected stage 2, and group C are those including mature B lymphoplastic leukemia, as well as those with CNS involvement and CNS disease. Group B includes patients who are not just previously mentioned in the previous groups. Actually, Burkitt is a highly aggressive B-cell non-Hodgkin lymphoma, and the prognosis for patients with Burkitt lymphoma has improved dramatically in the past decades, where local disease have an event-free survival of 95% and advanced stage disease have an event-free survival 70 to 90%. The prognosis for pediatric patients with relapsed and refractory Burkitt lymphoma are still dismal, with an average overall survival ranging around 25%. The treatment options is considered according to the risk stratification and the stratum of the disease, where low-risk group A receive 2 cycles of chemotherapy, as well as group B receive pre-phase chemotherapy, then followed by 4 cycles of chemotherapy, and those who have advanced features like stage 3 with elevated LDH receive 4 cycles of chemotherapy and associated with 6 doses of rituximab. Advanced stage C receive pre-phase and 6 cycles of chemotherapy, as well as maintenance courses and associated with 6 doses of rituximab. 20% of Burkitt lymphoma progress during initial therapy. Relapse occur in 20% as local disease, 20 to 30% as CNS involvement, and 10% have a bone marrow involvement. Relapse in Burkitt lymphoma occurs earlier compared to other large B-cell lymphoma subtypes, with a median time to relapse 4 months compared to 9 months after diagnosis in large B-cell lymphoma. Few pediatric data is available about refractory and relapsing Burkitt lymphoma, because fortunately we have few numbers of relapsing pediatric patients, as well as most studies discuss relapsing and refractory Burkitt treatment and outcome within other subtypes of mature B-cell lymphoma, despite they are having different biological behavior and different response to treatment. Also, some analyses are restricted to patients with relapse after initial therapy, and by this, they exclude like 30% of Burkitt who progress during the first line therapy. Different studies this French study has shown in 3 consecutive protocols, LMP protocols, the outcome of 30%, while the LMP 96 have shown that 2 years overall survival was even much more worse, constituting just standing for 20%. Also, the failure rate of reinduction chemotherapy regimen means fatal disease progression in 50% of cases. And this didn't vary across different salvage chemotherapies that are used. And also, only patients who reach complete second remission and receive a stem cell transplant have a chance to survive. And still, there is no clear advantage for allogeneic stem cell transplant over autologous stem cell transplant on the outcome. Some predictors of poor response include the progression during initial therapy, CNS or bone marrow involvement at time of relapse. The shorter the time to relapse, the worse the prognosis, the resistance to reinduction therapy, as well as multiple sites relapse compared to single site. Actually, Burkitt by itself as a histology is one of the poor predictors for outcome, and we can see here clearly that in non-Burkitt, the outcome is much more favorable than those who have Burkitt histology. In this slide that discussed and LMP study group has shown in this article many variables that were associated with the outcome, and they discussed that patients who have an LDH higher than 2 folds above normal, as well as patients who relapse less than 6 months, and those who are refractory to disease have a very poor outcome compared to other patients, as well as patients who have failed, who have relapse including bone marrow. they have a survival reaching just 2 years, 10%. Central nervous system, it accounts for 30% of relapses and occurs mainly in Burkitt's lymphoma. And its treatment should use intrathecal salvage chemotherapy and stem cell transplant. Also, some groups suggest cranial and craniospinal irradiation to improve the outcome of CNS relapse. Actually, the 5-year overall survival is not worse compared to other subtypes of relapses, and still ranging around the 30%, while a combined relapse that involve as well CNS have a decimal outcome reaching 0%. We can see here clearly as well that some of the predictors of outcome, including patients who have primary refractory and early relapse, not just decimal outcome, as well as those patients who had a response less than complete remission. None of them even achieved a median survival of 3 months, as well as those who were not transplanted. All of them died. Also, multiple sites relapse is associated with less outcome compared to patients who have single site relapse. And some are also associating the outcome to the doses of rituximab given, and assuming that courses less than 1,500 milligrams per meter square have an inferior outcome compared to patients who receive more than 1,500 milligrams per meter square, which is equivalent to 4 infusions, as well as the combination of stem cell transplant and rituximab have more favorable outcome compared to those who didn't use both modalities. So a general recommendation for treatment of relapse, we need to achieve a second complete remission with salvage chemotherapy, and this depends on the initial therapy given. So for group A and group B, patient could be upgraded to group C therapy. And for group C, we can shift to another lines that contain like carboplatin regimens like ICE, and rituximab is recommended in all relapsing patients. And to consolidate second complete remission, we need to transplant patients either with autologous or allogenic stem cell transplantation. And across different studying groups like the French group, the COG, and others, we can see that different salvage regimens have been used, and some of them incorporated rituximab in their salvage reinduction treatment, and still overall response rate was ranging from 50 to 72, with a complete remission rate from 30 to 50%. Also, the value of rituximab at relapse is discussed in a lot of adult and pediatric series, where in this study, in French LMP study, they showed that the outcome of patients who were reinduced at time of relapse with rituximab was almost equivalent to other studies that didn't use rituximab, with the outcome almost ranging around 30%. And the argue for the significance of rituximab at relapse is hypothesized in different theories, like the loss of CD20 expression at relapse, but still some studies didn't found this, and found the expression of CD20 is almost positive at the time of relapse, especially in the era that was not using rituximab in the initial treatment. As well as resistance to rituximab at time of relapse is also suggested in preclinical trials, and clonal heterogeneity at relapse drives resistance to different chemotherapies and immune therapies. Other studies like the Japanese study lymphoma group found that rituximab had a very good survival outcome compared to those who didn't receive rituximab at the time of relapse, with a very good 5-year outcome of around 50%, which is higher than a lot of other studies. And this could be explained by that 1/3 of their cohort contained or included large B-cell lymphoma other than Burkitt's lymphoma, which are known to be have good response to rituximab, as well as they denoted that all their patients who achieved less than complete remission with transplant or without transplant, their outcome was 0. None of them survived. And this newly published article that discussed the German BFM protocols, different successive protocols, and they showed that patients who relapsed and received rituximab have an outcome much more better than patients who didn't receive rituximab at time of relapse. And they also mentioned that the 4-year overall survival was much more better for those who relapsed after receiving initial therapy for low-risk group than those who were already on a high-risk group treatment and presenting with high-risk features. And also they compared the outcome of their Vichy protocol across with the other relapsing protocols, and they found that the Vichy protocol was associated with a better overall survival. And we can see here that 15 of their patients who received the intensified Vichy protocol and then followed by allogenic transplant in 11 patients, 10 of them survived till the end of their study. This raised also the attention of many other groups, and one of the just recently published was the RETOX trial that randomized patients to 2 arms. One of them received the LMP 96 protocol against same protocol, including rituximab, and they found that refractory disease or relapsing progression in the R arm was 3% compared to 15% in standard treatment, and they use this protocol in patients who have high-risk features like stage 3 with high LDH and stage 4 non-Hodgkin and Burkitt's leukemia. And also this reflected on a better event-free and overall survival in rituximab chemotherapy arm compared to chemotherapy single arm. Consolidating patients with stem cell transplant is also essential to achieve good outcome. And our options is autologous transplant, having the privilege of no GVHD, no immune suppression, but still there is possible tumor contamination, especially in patients with advanced stages or infiltration of bone marrow, as also exhaustion of stem cells from previous and prior intensive chemotherapy affect the yield of stem cells. Allogenic stem cell transplant is also an option with its possible graft versus lymphoma effect, as well as there is no prior exposure to chemotherapy for stem cells, but still there is the graft versus host disease and risk of rejection. Actually, allogenic benefit varies according to the non-Hodgkin lymphoma subtype, where Burkitt lymphoma, the outcome in allogenic and autologous didn't differ much on event-free survival, but it differs in lymphoblastic lymphoma with a better outcome in allogenic stem cell transplantation. Also, the rate of recurrence was equivalent in Burkitt's lymphoma in both strategies, autologous and allogenic, but more relapses was found in lymphoblastic and anaplastic using autologous transplantation. In this study also, besides that, it showed that complete remission patients have a very good outcome compared to patients who achieved less than complete remission. And they emphasized this also by showing that the only surviving patient in this study of Burkitt's lymphoma who was not in CR before transplant relapsed again and achieved CR3 after a second salvage chemotherapy followed by stem cell transplant. And they also showed that patients in complete remission before stem cell transplant always achieved early complete remission after 2 courses, which also highlights the importance of chemosensitivity before moving to transplant. This study also that included Japanese study, it included decent number of autologous and allogenic transplant, and they found an inferior outcome for Burkitt patient who were transplanted with allogenic transplantation compared to autologous. And in their analysis, we can see that this could be related mainly to the transplant-related mortalities that was higher in the allogenic group compared to the autologous group, but the incidence of relapse was almost comparative between allogenic and autologous stem cell transplantation. Many agents are tried in adult age group, and these trials, like the CAR T cells, like the checkpoint inhibitors, like the ibrutinib, but this small number of relapsing patients in pediatric age group, it didn't give the possibility for obtaining consistent results like adult results, as well as the difference in non-Hodgkin lymphoma biology in younger patients limits following large other trials besides the strict regulatory rules for experimental trial in pediatrics. Of those running trials is the ibrutinib combined with the RISE protocol, and the end of trial will be March 2024 with a preliminary result showing that 57% of cases have responded, that 21 of the patients have an overall response rate of 57%. Also, obinutuzumab, which is one of the anti-CD20 monoclonal antibodies, it showed in this study that will show its final results. It will complete the study in December 2021. It showed that obinutuzumab has an efficacy in rituximab sensitive as well as rituximab resistant, and all patients were included, responded, and could proceed to stem cell transplantation. The last study that we have is the chimeric antigen receptor T cell that is used in a fashion like a multiple CAR T cell infusion. And it showed that in patients, the overall response rate almost reached 100%, even in patients who failed to respond multiple courses of intensive chemotherapy and rituximab, and even in patients who progressed after prior CAR T cell, and they achieved a complete remission with a median follow-up reaching 1 year, and none of these cases have been bridged with stem cell transplantation, and concluded that CD19, CD20, CD22 multiple CAR T infusion have a promising efficacy in pediatric patients with the tolerable toxicity. So in conclusion, we can say that there is no current standard salvage treatment for relapsing and refractory Burkitt's cell lymphoma. The treatment options include salvage chemotherapy, autologous and allogeneic stem cell transplant. Rituximab combination therapy is effective in relapsing and refractory Burkitt's lymphoma who didn't receive rituximab as a primary treatment. Frontline rituximab in high-risk B non-Hodgkin lymphoma is meaningful to achieve better event-free survival. Actually, there is no difference in relapse rates between autologous and allogenic stem cell transplant, as well that we need novel immune therapy to improve the second complete remission rates before moving to transplantation. Thank you for your attention. Thanks a lot.
Thank you very much, Dr. Mahmoud, for, again, a very elegant presentation. Now I will leave the floor to Dr. Ashraf so he can present the next speaker. Please, Dr. Ashraf.
Thank you, Dr. Ala. It's a pleasure to be sharing this session with my professor, Dr. Ala Al-Haddad. It's really great to see him and to be with everyone. And it's honor to be introducing Professor Dr. Iman Ragab. Dr. Iman Ragab is well known for everyone. She's the pillar for the pediatric hematology oncology in Ain Shams University, the youngest generation, and she's outstanding physician and person giving great care to the patient. And I would love to introduce her to talk to us about lymphoma in inborn error of immunity or in immune compromised patient or immune deficient patient. Dr. Iman.
Bismillah ar-Rahman ar-Rahim. Thank you, Professor Ashraf, for the kind introduction, and I'm very honored to talk in front of my two mentors, my Egyptian version of mentor, Dr. Ala, and American version, and now Egyptian, Dr. Ashraf. I'll be talking about the lymphoma in inborn errors of metabolism. These are my agenda, and I will plot some case scenario that we face nearly 5 to 10 per year, and usually while facing the problem we cannot find a solution, so I'm just raising the problem here in this presentation. This one case is a 3 months old female, second birth order consanguineous parent. She presented by a fever of 3 months duration with large lymph nodes, very high ferritin level, normal triglyceride and fibrinogen was borderline. Epstein-Barr virus was high titer immunoglobulin M. So the patient was diagnosed as post-EBV or EBV-related HLH. The genetic analysis was sent because the patient has very aggressive clinical picture and the MARC13 was proved to be mutated. And at this point, we have done a lymph node biopsy, and we usually do not do lymph node biopsy in HLH yet. The result was ended up or came back with the small lymphocytes on an inflammatory background, like scattered large cells. The large cells were positive for 15 and 30 with diagnosis of Hodgkin lymphoma mixed cellularity. This was in 2015. In 2020, the end of 2020, we had a medical consultation from the immunology department that they had a child, 2.5-year-old, second birth order of non-consanguineous parents with history of sibling death. And on the right upper corner, they showed us her CT scan chest with multiple pulmonary lymph nodules or nodular lesion, and those lesions had high FDG avidity. The patient already had a genetic diagnosis of phosphatidyl inositol 3 kinase activating mutation. Pulmonary lesion biopsy were taken at this point with the result of atypical lymphoid cells, small to medium size, with aggressive inflammatory background with neutrophil and epithelioid cells. The cells stained positive for CD20, negative for CD10, and the high proliferation index was positive. And the first lab showed had a result of marginal zone benign Hodgkin lymphoma. And when we revised the pathology in another lab, the proliferation index was much lower, and they had the result of just atypical lymphoid infiltrate. So we're not sure we had a clonal disorder or just a polyclonal lymphoid proliferation. This is a frequent consultation from the immunology department. Are there rationale in their consultation about the possibility of lymphoma in the patient with immunodeficiency yet? Yes. In all age group, the lymphoma percentage or the malignancy percentage in the primary immunodeficiency patient is much higher than the general population. So we have to put at the back of our mind while managing pediatric immunodeficiency patients that they are liable to malignancy in general and lymphoma specifically. In the immunodeficiency cancer registry, when they looked at the immunodeficiency patient with lymphoma, they found the higher frequency with the ataxia telangiectasia, followed by the common variable immunodeficiency and the WAS, the Wiskott-Aldrich syndrome. In all the subtypes of the immunodeficiency, even in the old data, the lymphoma constitute the most common immunodeficiency among those patients. Talking about the immune-borne error of immunity, we include the primary immunodeficiency and the immunodysregulation. And while the international figure of prevalence of this disease is from 41 to 50, I guess in Egypt with a very high consanguineous rate, we may have, it's 41 per 100,000, not percent, sorry. So we may have a higher percent of or higher frequency of those disorders. In recent registry about the prevalence of immunodeficiency about these patients, and they put the classification just typical to the International Unit of Immunodeficiency. They found that the lymphoma was commonly or most prevalent about the ataxia telangiectasia, the Naegeli chromosomal breakage, and the common variable immunodeficiency. That's why those disorders are very closely followed for the development of specifically B lymphoproliferative disorder. Why the lymphoid system is the predominant site of lymphoma development or in those patients? Because they are very active, because they are this machinery is very active to provide diversity of B cell in face of divergent or discrepant antigens, especially in some point, like the VDG recombination step, the somatic hybridization step. Those steps are very important, and the somatic hypermutation, they are very important to provide different cells able to face different antigens. With those proliferation or active immune system, they should have a very strong DNA damage response, DNA repair system, including cell cycle checkpoints and apoptosis system, not only DNA repair. So the immunodeficiency, the lymphoma with immunodeficiency came from either defects in the lymphocyte themselves intrinsically during the development, or apoptosis defect like in patients with autoimmune lymphoproliferative syndrome, in their signaling in apoptosis pathway as well, like in HLH, in DNA repair system defect in telomere length like in dyskeratosis, for example, or extrinsic defect. In the presence of intrinsic predisposition, the risk of malignancy is parallel to the immunodeficiency state. So it's not following it like in the extrinsic predisposition when it's stimulated by viral infection and chronic tissue proliferation. And for sure, the very famous immune surveillance defect in those patients. The most important step and the most difficult step is making a diagnosis, because there is nothing black and white. Usually it's gray. Why is it gray? Because those patients are liable to infectious condition with atypical organism. If you look in the right upper corner, this patient has invasive fungal infection. In the right lower corner, this patient has pulmonary lymphoma with immunodeficiency. So they may be radiologically and sometimes even histopathologically very close to each other. So non-neoplastic proliferation and infection with atypical organism. This one of our patient had presented with autoimmune hemolytic anemia, and by scanning his chest, because he had external lymphadenopathy, we found that he had pulmonary infiltrate. And by revising the data of common variable immune deficiency with interstitial lymphoid proliferation, we found that most of the patients of common variable immune deficiency, they have some kind of lymphoid hyperplasia. And in some series, it reached to 100% of their patients, apart from the granuloma, not tuberculous, non-sarcoid in those patients, and infections. So to biopsy or not biopsy, we have to put everything under consideration, the clinical picture of the patient, the constitutional symptoms, and so on. And when we decide to biopsy the patient, which lymph node should to be biopsied? And in some suggested by expert opinion in autoimmune lymphoproliferative syndrome, they suggested to do PET scan and to choose the lymph node with the highest avidity to avoid taking other lymph node which has not have lymphoproliferation, which is did not turn into malignant. Sometimes the biopsy was not conclusive because those patients has non-neoplastic proliferation, inflammatory, or from the underlying defect, like the patient we had a PI3K mutation. Part of the disease is non-neoplastic lymphoproliferation, and those lesions may coexist even with lymphoid malignancy. So we may take a biopsy which proved to be benign, and beside it another lesion which is turned to be converted into malignant. What about the coloniality study? Because I was certain.
Dr. Iman, we cannot hear you.
إيمان الصوت مش موجود. It's a great case, Professor Iman, and we are waiting till your voice comes back. We have two excellent talks, Professor Sharif and Professor Hamad, great chair and co-chair, and the presentation of Iman is great, and I think she will come back in a minute. We have to work hard to diagnose such difficult cases and to do all the necessary history, clinical examination, and investigations. And I hope Iman will come in a minute.
Dr. Mohsen, we can get some questions answered for the previous two speakers in the meantime.
That's a great idea. If Khadija, you have anything on the floor, or Salwa, please go ahead till Iman is coming back.
I will use the privilege being one of the co-chairs and ask Dr. Hamad about the the cost for bone marrow transplant for a patient with Burkitt's lymphoma versus the cost of rituximab, just rituximab as upfront. I'm not sure how much difference that is.
If I got the question right, do you mean rituximab arm without being followed by transplant, or just?
No, talk about the cost of rituximab times 6 doses if you're going to use it upfront in the treatment of just the cost of rituximab, just per se, versus the entire cost of bone marrow transplant.
Yes, yes.
And
Actually speaking,
I can take this question on behalf of Mahmoud. The price, Ashraf, here in Egypt for rituximab is subsidized, and it costs actually like 200 US dollars, if not less, per cycle.
Okay.
Again, we're having a lot of approved generics, or I may say, in a better word, biosimilars, that is going to be offered for a cheaper price. So you're talking about 100 US dollars per cycle, which is not much. Again, Mahmoud can address the question of the cost of bone marrow transplant.
Yes, Dr. Ala, thanks a lot for this addition, because actually I don't know the dose of rituximab alone, but for transplant it costs here like it's really cheap. It costs like 250,000, including everything, which is, I think, comparable to that I'm speaking about matched sibling donor, and maybe much more cheaper for autologous stem cell transplantation, and compared to even other places in Arabic region or foreign regions, that's actually very good price.
Thank you. I think Dr. Iman is back. Iman, are you able to get your voice back?
Then we will keep asking questions. Again, I'm privileged like Ashraf, and I will ask Dr. Sharif. Many times we're facing tricky situations where the flow and the cytogenetics do not help you. In a way, you're having a Burkitt presentation, abdominal mass, leukemic infiltration in a weird place, and you do the flow, and sometimes you're missing the MYC translocation. Sometimes you're expressing a lambda or a kappa light chain, but again you're missing the translocation. And there was a recent article in Blood that included Burkitt lymphoma, and they stated that you have to identify the MYC translocation, or you have to be and they're stating like this: CD10 positive, BCL2 negative, BCL6 positive, and with a KI 67, 100%. They are labeling it like Burkitt. Am I entitled to consider these cases like Burkitt? Or if I feel that it's a Burkitt lacking the translocation, can I induce and then maintain like a leukemia? It's really a dilemma, and we don't know how to confirm with sequencing and gene expression profiling, just to have the feeling that it may or may not. So do you approve that for lacking translocation, BCL2, BCL6, and CE10 and KI67 is good enough, with or without a typical clinical picture for Burkitt?
نزل ايدك من على الكمبيوتر. Okay.
I actually do, Dr. Ala, and I'm sure you've seen thousands of patients over the years, and they don't really all read the book, and it's not exactly like the textbook. And quite often, there is a translocation. Translocation can be not the when we know exactly, it be a different kind of translocation, the slight modification in that translocation. For Burkitt's, for example, most of them 814 can get 802 or 822 with the light chain instead of the heavy chain. And that's why the approach is multifaceted. You got to put all of it together. You got to talk to you first. Clinically, the patient looks like Burkitt's. And then if the immunophenotype is very good for germinal centers, CCL6, CD10, Ki67, 100%. Morphology is good for Burkitt's too. There's a study, the NIH, and basically reclassified cases that looked like Burkitt's, but molecularly they didn't fit. So it gotta all fit together. And if it's 100% like the book, great. If it's not, then you have to put the things together and come up with the best answer. And that's why the latest classification, we back to high-grade B-cell lymphoma with features intermediate between diffuse large and Burkitt's, or similarly for Hodgkin. So there is no exact answer. I think we may be lacking some rare translocations that we don't pick with the current fish, or and that's why we more pushing into next gene sequencing for most of these cases. The latest ASH, not last year, the year before, we have a new classification. Basically, instead of 2 types, diffuse large, now the NIH come up with 5 subtypes based on MyD88 and Notch and others. The Margaret Chip from Boston, from Massachusetts, came up with a classification. She claims it's a little better. It can divide diffuse large B-cell lymphoma into 4 subtypes and is able to pick up Burkitt's all the time. So I don't think we have a 100% answer. And in these cases, it's got to be really communication and putting all the things together.
Thank you very much for your answer, and waiting for Iman. Are we back in business?
Man, send the presentation to Dr. Khadija, and she will try to open it from the phone. So we give like one minute more. What I would like to say that the standard of discussion, for me, it looks like what happened in SIOP or in ASH. The level is too high, but that's the real current practice for in 57 and in New York and in Ain Shams, with the support of Iman Ragab and the team, for the best for the patients, because any chance for the patient to improve the outcome, either through better diagnosis, personalized treatment with the following the guidelines. I see Professor Reiter among the group of the BFM group, and he was one of the Espho speakers, and Shrape, and both of them, when they come to Egypt, they ask me if they can take Iman and the rest of the team, Fatma, Nayera, with them to either Germany or Italy. But of course, I said to them, no way. They said just a couple of months of German or Italian, then they could come. I said, no, only Arabic. They don't speak English even. Khadija, if you have information, go ahead.
طب ابعتيها برضو كده ماشي. هنبدأ مع سلوى. اوكي.
Dr. Ashraf, you read to present Dr. Salwa?
Yes, please, Dr. Ashraf. Dr. Iman will join later, so we can go ahead.
It's with great pleasure to present Dr. Salwa. Dr. Salwa is lecturer at Ain Shams University in the Department of Pediatric Hematology Oncology, and she's one of the fascinating persons and also caring physician, and one of the very fast-growing, elegant and great oncologists. She's going to present her 2 cases, and she usually have very good cases to present and stimulate our brain. Dr. Salwa, please go ahead.
Thank you, Professor Ashraf, for such elegant presentation. Thank you, Professor Dr. Mohsen. Let me start with the cases we are presenting
سلوى
today.
قدمي شويه قريب. ايوه عشان تباني. ايوه كمان شويه.
Okay, let's start our first case. She is a female patient, 2.5 years old, second order of birth of non-consanguineous parents. This patient was presented to us June 2021 with 1 month history of high-grade persistent fever, weight loss, as well as dry cough, which was followed by the development of dyspnea, chest pain, and orthopnea 2 weeks after her initial presentation. Upon examination, she was distressed, toxic, feverish, with pallor. Her heart rate was 190. Otherwise, she was vitally stable. The neck exam showed no peripheral lymphadenopathy. Her chest exam was positive for bilateral diminished air entry with scripts, and she actually had RD grade 2 to 3. Her heart exam showed distant heart sound, and she did not show any organomegaly. This was her initial chest X-ray. Her initial laboratory investigation were significant for mild microcytic hypochromic anemia. ECR was 100. Her LDH was 750. She did emergency echo and it showed pericardial effusion, which was moderate. Her emergency CT chest was positive for bilateral consolidative pitches, more over the right side, and she was labeled, according to our radio department, to be of intermediate probability for being COVID-19 positive. As we are in COVID pandemic, we suspected she is having COVID, and we actually found such cases report about children COVID-19 positive presenting with pericarditis and pericardial tamponade, and they are screened positive for COVID-19 by PCR actually. She did COVID-19 investigation. She was positive, weak positive for COVID IgM. IgG was negative, and her COVID PCR was negative. But according to her presenting condition, she was admitted to our VICU and was considered post-COVID-19 case of pericardial effusion and was treated at CHAST. She received IVIG. She showed elevated D-dimer, was critically ill. She received anticoagulation, steroids, colchicine, broad-spectrum antibiotics, and cardiac support was managed by VICU team according to her condition. She performed actually pericardiocentesis, which showed serous sanguineous fluid with many RBCs, elevated proteins and LDH, and culture negative. Otherwise, in her PQ admission, follow-up echo showed recollection of the pericardial effusion. There was no improvement neither in the condition nor in the fever. She was still feverish. She repeated her COVID-19 PCR. It was still again negative. 2 weeks later, following her PQ admission, she started to develop rapidly enlarging cervical lymphadenopathy, as well as abdominal distension and vomiting. Pelvic abdominal ultrasound at this time showed splenomegaly, as well as intussusception, and she performed for such urgent pneumatic reduction. So far, our case is a case of presenting fever, recollecting pericardial effusion. She also developed myelopapillar rash in her ICU admission, her lymphadenopathy, intussusception, and appearing splenomegaly with a presumed COVID-19 infection. We started to suspect her as having MESI. What's MESI? MESI is the multi-system inflammatory syndrome in the children, which was defined last June by the CDC. It needs inclusion for the patient to be diagnosed as MESI as having history of fever, more than 38, more than 24 hours, with more than 2 systems to be involved and positive for COVID-19. Actually, although she had positivity for the skin rash, she had lymphadenopathy as well as her cardiac affection. But they are stating that the patient should not have other alternative diagnosis so as to be labeled as having MESI. At this point, our patient repeated her scans, and this time there was suspicious looking cervical axillary and mediastinal lymphadenopathy, still having pericardial as well as pleural effusion. She had hepatomegaly, abdominal, and pelvic lymphadenopathy. I had a moment for patient, she is a case of fever, she is a case of recollecting effusion, skin rash, intussusception, added now mediastinal lymphadenopathy, generalized lymphadenopathy, splenomegaly. And she's with presumed COVID-19 infection. which is COVID-19 IgM, was B positive, and PCR done twice, and it was negative. We started to see might be malignancy, social media biopsy, which is not indicated in the case as suspected. Actually, another biopsy, which is shown to be muscular syndrome. Bone marrow and CSF examination, both were free for seconds. A beta showed lymphadenopathy with high avidity below diaphragm, splenomegaly, otherwise was. Accordingly, she's a case of ALCL, stage 3. She started her BFM protocol treatment, and last updates on her condition, she's very stable, no more fever, no more pericardial connection, very vitally stable, admitted in the ward, completing her chemotherapy successfully. My second case, it's a 4-year-old male patient, third order of first non-consanguineous parents. He was presented to us February 2021 with 10 days history of fever, classic abdominal distension, abdominal pain. His examination was free apart from the standard lax abdomen with palpable suprapubic mass, non-tender firm, measuring 5 times 6 centimeters. His initial laboratory investigation was significant for elevated ESR. His LDH was 590 and uric acid was elevated. He did initial CTs, which showed enlarged lymph nodes above and below diaphragm, and there was significant amalgamated abdominal retroperitoneal lymph nodes encasing vessels with calcification, and another soft tissue density seen at the right iliac fossa, as well as splenomegaly with thrombosis inside splenomegaly. He was suspected to be a malignancy versus benign condition. He started anticoagulation therapy, and tuberculin test was done and showed to be negative, and he performed abdominal lymph node biopsy at that time was still pending. 2 days later, the patient developed severely agonizing abdominal pain after his biopsy with infrequent vomiting, yet his intestinal sounds were audible. He did the abdominal ultrasound was uneventful except for the masses, as well as his portal vein thrombosis with partial flow occlusion. His biopsy result was out, and it showed his having Burkitt's lymphoma. He did bone marrow and CSF. Again, they were free of any infiltration. He was staged as a stage 3 according to the BFM risk classification. He is R3 and started his BFM protocol of therapy. He just ended his second chemotherapy, and he did a follow-up abdominal ultrasound, and it showed recanalization of both splenic and the portal vessel, and he discontinued his anticoagulation therapy safely. last thing عايزة أقول شكرا لوحدتنا الجميلة كلها. My mentor دكتور إيمان رجب، شكرا يا دكتور. دكتور فاطمة، دكتور دينا، دكتور خديجة، مروة ونهال، آلاء، ميرنا وخالد وهدى ومايكل وكل our residents. Thank you all, and thank you for all attendance.
Thank you, Dr. Salwa, for the great presentation and very challenging cases. And I would take the few minutes to comment on those two cases, and then we can open the floor for questions. Can you see my screen?
Yes, clearly, Professor Ashraf.
Okay, so I'm going to comment on the first case, which is very unique that Dr. Salwa presented. It's interesting for, number one, anaplastic large cell lymphoma is not common in pediatrics. Usually it start around the age or peak around the age of 12, which is the teenager, and younger kids usually have less prevalence of the anaplastic large cell lymphoma. But the case actually demonstrates very important thing, which is hemophagocytic syndrome in presentation with malignancy or in association with malignancy. And I'll tell you why do I think about that. And the way it was presented was the inflammatory syndrome sort of picture. The patient came in with serositis, with pleural effusion, pericardial effusion, what thought to be pneumonia, in addition to fever, high ferritin. So picture of inflammatory or multi-system inflammatory disorder. In the COVID time, of course, everyone will think about COVID. So first, I would like to really congratulate the team taking care of the patient, whether in the PICU or the hem-onc department, of keeping this patient alive, to be honest with you. This is a very sick kid. And then the kid developed intussusception, which again is very interesting. In this age, still she's young. So intussusception in this age, you think about infection, not lymphoma. We know in older kids, like 6 years or older, when you see intussusception, you will think about lymphoma. But the kids is just 2.5 years old. So it's very strange. And then skin rash. Picture, Salwa, I would suggest that this is a picture of multi-inflammatory disease or multi-system inflammatory disorder that can be more than one thing. If COVID is negative, then it's negative. But what else presented here to point out to ALCL or anaplastic large cell lymphoma? This is a boy, if I remember correctly, which is more common in boys than girls. There is systemic inflammation or systemic symptoms, especially fever. There is extranodal location, and it's well known in anaplastic large cell lymphoma that extranodal, especially in the lung and the skin, is about 15%. So 15% of the cases with anaplastic large cell lymphoma will present with a skin lesion and or lung lesion. And 12% of the patient will present with hemophagocytic-like syndrome. So when you put things together, the only thing that doesn't fit perfectly here is the age, the young age, but things happen. But when you put everything else, you can see that this is an anaplastic large cell lymphoma, high grade, high stage, stage 3, presenting with multi-system inflammatory response with fever and serositis, and possibly the lung could be infection or it could be inflammation. It could be from the lymphoma itself. And we know that 12% of the ALCL will present with hemophagocytic syndrome. So that will raise the question about the prevalence of malignancy in hemophagocytic syndrome, because Dr. Iman mentioned also earlier in her presentation about the case that they did. It's not usual that we do lymph node biopsy in the setting of hemophagocytic syndrome, because we all know lymphadenopathy is one of the criteria, or one criterion of the criteria for hemophagocytic syndrome. But about 25%, and I want every one of the junior faculty to remember that in 25%, meaning quarter of the patient who develop hemophagocytic syndrome is secondary to underlying malignancy, and lymphoma and T-cell malignancy especially is a very common underlying. So when you have hemophagocytic syndrome, always think about malignancy because it can be hidden and you need to find it out because the treatment is going to be different. So that's really important in this case. This is one example of the skin lesion that can present in anaplastic large cell lymphoma. It's not exactly the same like the patient have, but just show you that it can be present like that. I will stop commenting on this case, and I'm not sure if Dr. Mohsen want to open the question about the case, and then we can move to the next case, or should I comment on the second case?
I think you comment on the second case, then we open the discussion for.
Okay, so on the second case was one of the common, again, which is basically the the non-Hodgkin Burkitt's lymphoma. And my question is, it's typical for presenting non-Hodgkin's lymphoma, but the challenge here was thrombosis. So it seems that this patient had portal thrombosis at presentation, which can make things much harder. And we know the presentation for Burkitt's lymphoma can be very, very challenging because the kid can be very sick. The question is it thrombosis because of tumor invasion or thrombosis because of clot or both? And it's very hard to tell that this is both because it's, which one? Because it's within or very close to the tumor. So invasion can be definitely a big contributor to this. In addition to when you have invasion, that will lead to secondary thrombosis also. But how can you improve the outcome for Burkitt's lymphoma? I remember very well my professor, Dr. Ala, when I was talking to him before I was in Egypt, and he said, Ashraf, there is certain cancer that you have only one chance, either you get it or not. And Burkitt's lymphoma is one of those examples, actually. It's either all or none. As our elegant presentation showed that in Burkitt's lymphoma, the outcome of relapse is very, very dismal or very poor. We know that we have only one chance, which is first chance of curing Burkitt's lymphoma. So if this is the case, then how can we improve the cure of Burkitt's lymphoma? And Mahmoud already pointed out to using rituximab, was just published in the New England Journal of Medicine, that adding rituximab to the upfront therapy of Burkitt's lymphoma can increase or improve the survival by about 10%. So this is the chemotherapy alone without rituximab, and this is the rituximab arm. It increased by about 12%. So it's definitely, when you're talking about improving 12%, that you're going to remove them from relapsing to being cured, that's a huge thing. That's why I asked my question about what is the cost of using 6 doses of rituximab, which if we calculate it, if it's like 1,500 Egyptian pound or 2,000 pound times 6, that would be 12,000 versus 200,000 for transplant. And also not sure if the patient will survive it or not. That definitely tells you it's worth it. I'm not saying that we will not need transplant, because at the end of the day, you will need transplant for some patient. But if you can cure them upfront, definitely consider it. The issue is, if we're going to consider rituximab, I wish it's easy, said and done. But to do it, there is some side effect, and the institution has to think about that, about the availability, about the side effect, increasing possibility of increasing infection, and so on and so forth. So it needs to be thought about, but definitely it's worth it. So this is one example of just adding one thing can improve the survival by about 15% or 12%. Another way of maximizing the upfront cure rate for Burkitt's lymphoma, and I'm talking about not stage 1 or 2, because the outcome in stage 1 and 2 is about 99%, but I'm talking about stage 3 and 4. And if you look at treatment, you will know that treatment for Burkitt's lymphoma depends on 2 important things. One is dose intensity, and 2 is dose density. And dose density means you don't give chance between the chemo and the next cycle. You just give it back to back once the patient recover, because we all know that Burkitt's lymphoma doubling time is about 12 hours. So you really don't want to leave any time. So you have to be really on top of it. That's number one. Number two, the higher the dose of chemotherapy you're using seems to be the higher the cure rate, and we'll see that. This is one example here. Sorry, the BFM used methotrexate in 2 different forms, either 4 hours or 24 hours. And when they looked at the low stage, which is stage 1 and 2, there was no difference between 4 hours and 24 hours. But why are they checking that? Because we know the toxicity of methotrexate is higher when you do it longer infusion. So they were trying to shorten the infusion of methotrexate. In stage 1 and 2, there was no difference. Whether you give it on 4 hours or 24 hours, the cure was the same, but there was big difference in the toxicity and mucositis. 50% reduction in the mucositis happened when they give it over 4 hours. They tried to do the same thing on higher stage, which is stage 3 and 4, and they found big difference it dropped from 93% to 77% cure rate. So the 4 hours infusion in patient with high stage Burkitt's lymphoma was not good idea, and they had to give it over 24 hours. I'm talking about the BFM protocol. The LMB protocol is different story here, but I'm talking about that because in Ain Shams, they are using the BFM protocol. So using the methotrexate on longer time, it seems to be very effective because again, it hits the cells when they are dividing. Another way of improving the outcome is, as I mentioned, the dose intensity and dose density. And there was one interesting thing on the LMB. They found that if you have some delay between course 1 and course 2, copadam 1 and copadam 2, more than 21 days, there was 8% reduction in survival. This is a big thing. So if you delay, we usually say, oh, let's wait for the patient to recover a little bit more. Maybe he needs a little bit more count and needs a break or something like that. You don't give break in Burkitt's lymphoma. In Burkitt's lymphoma, you go boom, boom. You don't want to wait between the cycles. Just you wait until the count recover according to the parameter and you go on. So if you wait between copadam 1 and copadam 2, it seems to be this is enough time that the tumor can grow back again. So basically 8% difference in survival if you wait. The other thing that was reported through the LMB trial is the higher the stage of Burkitt's, the higher the dose of methotrexate you need. So for stage 1 and 2, you need only 1 gram of methotrexate over 4 hours. So the toxicity is much less. But for stage 3 and 4, you need, especially for 4, you need 8 gram of methotrexate. And then the BFM, you have to do it on 24 hours infusion. Last point here is the residual mass in Burkitt's lymphoma. It's not uncommon to, after you finish the first 2 cycles of chemotherapy and you go to the 3rd cycle in the LMB and you want to assess the patient response, you see some residual massing. And the question is this viable tumor or not viable tumor? How can we tell? It's very hard again because unless you resect this residual mass, you will not be able to tell for sure. The problem is it's abdominal usually, and resecting the mass will lead to maybe some resection of some other organs, especially the intestine, and lead to delay in therapy. And we just mentioned that delay in therapy is not a good thing. So is the PET scan helpful in finding out if those patients are having viable disease or not? Let's look at that. And actually it's published by the NCI group in Cairo, which can PET scan replace biopsy for evaluation of residual tumor in pediatric mature B cell. And what they concluded is there is definitely a negative predictive value, which is about 86%, but the positive predictive value is about 60%. So in other words, if the PET scan tell you that it's positive, don't believe it because it can be just dead tissue or inflammation more than anything else which happen with this necrotic tissue. And you cannot really upstage the patient and move him to higher risk category just based on positive PET scan. If it's negative, it carries more weight. It's about 90% negative predictive value. So you may say, okay, you know what? I'm not going to subject the patient to surgery. If I put him through surgery, I'm going to delay the chemo. I'm going to have this and this and this. And let me try to do maybe multiple needle biopsy or true cut biopsy. Or if you decided not to do anything and wait and see, you have some ground to stand on it. So again, PET scan is not ideal, especially if it's positive, but it's helpful if it's negative. Last is keep in mind or keep your guards up when you're treating Burkitt's lymphoma. Burkitt's lymphoma is one of the very, very tough tumors because of the following. You want to keep this patient alive, but you will see that the morbidity and mortality, especially mortality, is about 15%. Tumor lysis is a major problem and major cause of death. Mediastinal syndrome in patient with lymphoblastic lymphoma, of course, not in Burkitt's lymphoma. Sepsis, perforation during treatment, and progression. And this is again a published abstract by the NCI group in Egypt, looking at a really good number, 570 patient, and they found 15% mortality. So this is really in one of the best hands of oncology in Egypt, and they are quoting 15%. And this is a recent one, I think, in the last published in the last 6 or 7 years. And the 15% mortality was mainly due to septic shock or sepsis, tumor lysis syndrome. So 12% died from tumor lysis syndrome and 35% died from sepsis. So again, keep your guards up when you're treating Burkitt's lymphoma. I'll stop here and open for question. Thank you.
I think we have Professor Iman. If she's with us, we can share the screen before the questions answers, or what do you think, Professor Ashraf?
We still have time, so if Iman there, I think we definitely have a few minutes for her to continue.
Right, I think we can get things done with the Q&A, and then she can resume the presentation if you don't mind.
Sounds good.
Okay, because yani, for interruption and everything, thank you very much, Ashraf, for your comments on the large anaplastic and then the Burkitt. And I'm having a small comment. Right now, we're changing our protocols. And again, you quoted the New England Journal of Medicine, and it's strictly for the high-risk patients. That's to say, stage 3 with high LDH or stage 4 or Burkitt leukemia only. So you could see really a benefit in the high-risk patients, and at 357 and at the National Cancer Institute, we are adopting the LNB protocol. And then right now we are including rituximab like a standard of care for Group C patients, all Group C patients, not Group B, not Group A. And we are assuming that we can get benefit from adding rituximab. Definitely, it is not coupled with increased toxicity, and it has been shown in so many other studies. And we are expecting, as I said, a better event-free survival. But the problem in the management of Burkitt with a bulky, very advanced late presentation cases, it's in their tolerance to chemotherapy. Once you're giving them a prephase of cyclophosphamide, vincristine, and steroid, they are getting into severe toxicity, sometimes perforation and bloodstream infection and ICU admission, and you could hardly be able to support them. In my wildest dream, you could never challenge them with aggressive chemotherapy, and the maximum that you can do in so many cases is a second CVP. Not because that we don't know that it's really important or we need to keep the dose intensity and the dose dense kind of approach, but because simply you cannot, and simply you lose a lot. And I believe in best hands, you cannot help it. We need to work on getting these patients into specialized centers and to get treated as soon as possible, because sometimes you cannot believe how much delay in a Burkitt can be, unfortunately. Sorry for being late.
I agree with Dr. Ala with all what you said. As you said in the rituximab, yes, it's the benefit is in stage 3 and 4 because 1 and 2 is already like 95%. So there is no, probably added benefit, or it's hard to prove it. But yes, I was reviewing some of the articles published from Egypt again, and 75% of the cases of Burkitt's lymphoma or even more are advanced at stage 3 and 4, and patients are having severe malnutrition for sure. So that's more than what is recorded or quoted in the Western countries, where it's about 50% or 50-50. And also, as Dr. Ala said, it's very hard to keep a kid with Burkitt's lymphoma between tumor lysis and infection. You're really in very tough spot. And I agree with you, Dr. Ala, because you might add some benefit or presumed benefit by adding something like rituximab, but then you see the infection is going skyrocketing. And that's not beneficial. So that's why I said it has to be decided in institution by institution or at national level. And we have to be really ready for what we're doing. It's also good to do the methotrexate in 24 if you're on sort of BFM, but it's if you see the mucocytes going up to 50% and the infection, then there is no point of doing it because you may lose more patients. So it's a very delicate balance, and I agree with you 100% with your clinical sense and everything of how can we balance the toxicity and the intensity and the cure. Very tough, but it's very evident in Burkitt's lymphoma. Thank you, Dr. Ala.
I cannot agree more. Again, one question to Dr. Mahmoud Hamad. And I am a transplanter, and I'm not expecting to transplant all Burkitt's. We don't want to do this. And as Mahmoud said, if you manage to get them into second CR, then they can get better. Otherwise, you will have like 10-20% maximum event-free survival if you're having any. Could be a 0. Right. I'm still biased to allo BMT, auto and allo. It's there is a good quality of evidence in doing an auto and again in allo, and I'm a little bit biased for HLA identical sibling donor, especially when we are talking about the group C with bone marrow infiltration. If we don't have a matched donor, we go for auto. I'm still doing this. We revised our data, and I could see that maybe we're getting a better outcome with the allo for those who were offered an allograft. And again, you could see here in Egypt, we're talking specifically about HLA identical sibling donor, not an unrelated or a mismatched or a haplo-identical donor. We're not offering such an option for our Burkitt's. And if you manage to get them into CR and they don't have a donor, we offer, again, an auto transplant, especially if they are not having an advanced disease from the start. So to Mahmoud, you prefer to go for auto only, and to Ashraf, do you consider allo in your Burkitt?
Dr. Ashraf, just please. Okay. I think, Dr. Ala, that's a nice question. I would prefer allogenic stem cell transplant, as despite I didn't find much of support from literature in that point, but it was mainly related to transplant-related mortalities. And so long we are speaking about matched sibling donor, so I think it's a good balance to transplant, especially advanced cases with allogenic stem cell transplant matched sibling donor. So long I still have in the background a feeling that there is some sort of graft versus lymphoma, which we could benefit, and many studies are speaking about graft versus lymphoma, maybe in other subtypes, not specific for Burkitt's lymphoma, but I would rather go for allogenic stem cell transplant.
We go for allo، زي ما حضرتك قلت في مصر الميزه ان هو الدونر حاضر، مش هياخد وقت. احنا بنخاف من الالو انك علشان تلاقي دونر ممكن ياخد وقت لو ما عندكش الماتش سيبلينج، والعيانين بتوع البركتس ليمفوما ما تصدق ان انت to get them into remission to transplant them very quickly. But in case of matched sibling, the sibling is right there, and as you said, if it's in good hand, like you have been really doing great in the transplant, the mortality will be less, and the again, the graft versus lymphoma effect might be beneficial. As Mahmoud said, there is no standard of care for those patients. You're trying to do the best, and the transplanter, we go by the transplanter's opinion, to be honest with you, because if he or she feels good about it, then we'll go for the
yeah. This is exactly what this is exactly my feeling. And one last comment, and then I'm concluding to Mahmoud. Ironically, and I don't know, probably, you know, there is now in US 31 CAR T cell in pediatric Burkitt lymphoma, and you will be astonished. I was astonished when I was reading the updated trials of the results. It's probably very effective, and is being coupled with PD-1/L1 blockers to augment the response, and they're getting very encouraging results. To cut a long story short, definitely you're having some kind of an immune therapy, and in Egypt you can say you're definitely having a graft versus lymphoma or Burkitt lymphoma effect, so long that CAR T in Burkitt lymphoma is working. And thank you very much.
Would you, the question back to Dr. Ala, would you think it would be a bridge or a replacement for stem cell transplantation?
The CAR T?
Yes, as in acute lymphoblastic leukemia.
No, yes. Ashraf can say it's a very good question. At this point of time, it is definitely a bridge. If it is left up to me, I'm a transplanter at the end of the day. But again, you're talking about the persistence of the CAR T cells, and are they going to be persistent or not? And there are a lot of tricky things in the setup of Burkitt lymphoma, the microenvironment and the lymphocytic infiltration, and that's why they are mentioning to use it with PD-1 blockers so they can augment the immune therapy. So if it's sustainable, maybe in the future, then you can consider not to go for a transplant. But at this point, I would recommend the use like a bridge. And again, when I'm telling you it's working, and if you are into the technicality of CAR T and the time to manufacture CAR T, and you're talking about Burkitt, and then you have to have a turn around time very fast, so you can outpace the tumor. It's pretty difficult, but it's working. And once it's working and you get your patient into a remission, I believe that you need to consolidate.
Okay, thanks.
Dr. Iman?
Yes, I did all the efforts to go back to the presentation, and I have this deep feeling that that's what's going to happen. Don't ask me why, but I had this feeling. So back again, we are stuck that we do not have an easy tool to diagnose, or there is no crystal clear diagnostic criteria for turning into malignancy in those patients. Next, please. Next again. So the diagnostic challenge that, yes, in the clonality study, in the previous one, the clonality would not solve, because some of the non-clonal disorder or polyclonal disorder are very aggressive, and they may need aggressive immunosuppressive therapy, and some of the clonal disorder are less aggressive. So sometimes the clonality would not solve the problem. Next, please. In a way tool to gather the different pathology and ending up by a similar different pathogenesis, ending up by a similar pathology. The Europeans, next please, the European Association of Hematopathology, they gathered like a common nomenclature for all immunodeficiency associated lymphoid malignancies into three category or three type of mentioning or nomenclature: the name of the lesion as per the closest WHO, the name of the virology if positive, and the specific immunodeficiency background. Next, please. So, and if you look at this slide, they put like, for example, it's a bleed cell hyperplasia polyclonal type with Epstein-Barr virus positive in a positive transplant setting, in a PI3K mutation, and so on. This why they put this, because sometimes the immunodeficiency background may impact the decision of treatment. For example, in the PI3K, in the case I mentioned, they use mTOR inhibitor, for example. Next, please. And in all the immunodeficiency, like in severe combined immunodeficiency and CVID, the predominant stimulator is the Epstein-Barr virus, still like the PTLD. That's why in the next slide, they put in many of the lymphoproliferative disorder related to immunodeficiency the same progress criteria in the PTLD, starting by the B-cell hyperplasia with a non-destructive lesion, ABV positive, and progressing to polymorphic B lymphoproliferative disorder, and characteristically they are polyclonal, and they have destructive lesion. And then the indolent B-cell lymphoma, like our patient with the nodal, although I put a question mark because they have high proliferative index within nodal and extranodal marginal zone lymphoma, and ending up by the very peculiar, like in the WHO, aggressive B-cell lymphoma. Next, please. يعني خديجة ممكن يعني وانا يعني ماشي اسرع لو تحب. So it's in, for example, in the polymorphic B cell proliferation, the lesions are, although polymorphic, they are destructive, and they do not they do not show clonality but some part of them they show clonality. So that's why it's very confusing where to put the patient in which criteria. Is it aggressive? Aggressive does not mean in all circumstances aggressive clinically, does not mean it's not equivalent to clonal disorder. That's what I mean. Next, please. So the aggressive B-cell lymphoma, for example, in the immune deficiency stage, there is a mixed background of inflammatory cell, and we cannot, sometimes even you cannot specify the patient as clear Hodgkin and clear non-Hodgkin, and sometimes even the immunophenotype it show a continuing between T-cell histiocytic rich B-cell hyperplasia and classical Hodgkin lymphoma. Regarding the T and natural killer cell lymphoma, it's not common in the immunodeficiency lymphoproliferative disorder, and what's reported in the T cell leukemia and the T cell pro-lymphocytic leukemia in the setting of ataxia-telangiectasia. Okay. As regards the pathological subtype, when you compare the primary immunodeficiency and the normal patients, there is some prevalence of some rare immunopathological subtype, like in the centroblastic immunoblastic constitute in the primary immunodeficiency patient 31% compared to 8% in the normal non-immunodeficiency patients. Next, please. And in the patient, in the large series of 50 plus patients with the activated phosphoinositol kinase, like our patient, there was a large percentage of patients with marginal zone lymphoma, although predominantly they have diffuse large B-cell lymphoma, and Hodgkin, that they have a large percent, like our patient with the marginal zone lymphoma. Next, please. Coming back, apart from the different rare pathology, we have also rare sites like pulmonary infiltrate. When pulmonary infiltrate, we think usually of a fungal infection, yet we have to put in the differential diagnosis the pulmonary lymphoma. And although they are rare lymphomas, that the outcome as well is guarded, and many of the recorded patients with the pulmonary lymphoma had a background of immunodeficiency and had a dismal outcome. Like in this series of 4 patients, all of them died of disease. The primary CNS lymphoma as well, we have to think in the pediatric age group of immune deficiency, you have to go for the full immunological profile. And when we compare the survivalship between the CNS lymphoma in immunocompetent versus immunodeficiency, there was at least 30%, so 30% decline in the mortality rate. And when we look at the right side of the slide, some of the lesions are very similar to the infections with ring-enhanced lesions. They are very similar to infections. So biopsy would solve the problem here in diagnostic criteria. So going from proving its lymphoid cells, lymphoproliferation, neoplastic lymphoproliferation, aggressive lymphoma, and very specific peculiar type like EBV positive diffuse large cell lymphoma is not an easy job, requiring many of the very big battery of immunohistochemistry and cytogenetic analysis, and a clonality study is useful as well. When the patient presents back as lymphoma, we have to take a proper history of infection in this patient, a family history of inherited immunodeficiency of consanguinity, the unusual presentation of histopathological subtype, of the strong inflammatory background in the histopathology, the unusual site and unusual infection post-treatment, and severe toxicity. We have to think immunodeficiency in such patients. Next, please. And when we think immunodeficiency, we have to categorize into immunodeficiency associated B and T in the approach to treatment. Next, please. In managing those patients, we have to put in our mind that the very intense supportive care should be taken. We have to follow immunologically repeatedly by immunoglobulin assay, and this take more profuse or easier decision of immunoglobulin replacement, more microbiological diagnostic, more prophylactic antibacterial, more prophylactic intravenous immunoglobulin, and more growth factors in such patients. The treatment strategy would be including in a dose reduction strategy and increasing interval between the chemotherapy cycle to allow for the bone marrow recovery in such patients. And again, talking either inborn error of immunity or DNA repair disorders, because in the DNA repair disorder, we have to modify significantly, avoiding radiation as diagnostic, avoiding frequent dosing of vinca alkaloids. We have to space the dosing because of the neurotoxicity is higher. We have to give more profuse mesna during the cyclophosphamide regimens, and to reduce the topoisomerase dosing, some regimen by 25% and some regimen by even 50% to avoid toxicity. And for sure, the non-genotoxic therapies are now predominantly not only rituximab, the high PD-1 and PD-L1 expression give more courage to use of anti-PD-1 and anti-PD-L1 in such patients. Next, please. Is hematopoietic the gold standard in such patients? Many centers, after sending the patient in the first remission, they would consolidate with transplantation, but it would not solve all the issue in some of the immunodeficiencies, like for example the ataxia-telangiectasia. So the state of some of the decisions are not fully answered with the state of response prior to transplant. The optimal conditioning myeloablative after transforming into malignancy would be myeloablative versus reduced intensity, and the risk of secondary malignancy is there because the genetic background is still there. And the outcome for sure of those patients are much lower than the patient without immunodeficiency. For example, in the patients in the right-sided part of the slide, in 62% in the patient with immunodeficiency and lymphoma, comparing to 73% in the patient with non-immunodeficiency. Next, please. And in the CNS, primary CNS lymphoma, the event-free survival reached to 40 plus 45% survival rate. With more dismal outcome, the ataxia-telangiectasia, most of the reported cases, they did not survive their malignancy, and this is very bad news for the ataxia-telangiectasia because we have recently tried with ataxia-telangiectasia and lymphoid malignancy. Next, please. So, like the Turkish publication recently in pediatric blood and cancer, malignancy and lymphoid proliferation in primary immunodeficiency, they are hard to define and hard to treat. And we have to do an Egyptian registry. Like I always say, we have to do consensus and regard the basic battery for pathology, including the EBR and the chronality. We have to have consensus on treatment. We have to respect the genetic diagnosis, because sometimes we think of the end of the line, the pathology, and forgetting the initial genetic diagnosis. We have to accept the gray zone in the pathology and the rare pathology, because we did not accept the patient with the marginal zone lymphoma in our patient. I will thank very much the immunology team for sharing the patients with us with the query immunodeficiency. And يعني الله يرحمه Professor Dr. يحيى الجمل يعني he had يعني أيادي بيضاء on all of us. ربنا يرحمه. And I will thank my team, يعني seniors and juniors, and thank you to my patients. And this is the end of, alhamdulillah, the end of my presentation.
Thank you, Dr. Iman, for your comprehensive overview of the immune deficiency and lymphoma. And I think we'll open the floor for questions and answers. Dr. Khadija, is there any questions coming from the floor?
Until now, no. I think Dr. Salwa have a question.
We have like a couple of minutes for the question and answer. Thank you very much.
We have a question from Professor Mahmoud Hamid for Dr. Ashraf. How can you manage new cases of non-Hodgkin's lymphoma with COVID?
So that's very tough one. يعني دكتور علاء كان لسه بيقول احنا يعني بالعافيه بنحاول نمانج العيانين بتوع البركتس ليمفوما and it's very hard. So how about when you have COVID on top of that? Are you talking specifically about anticoagulation? Because I'm not sure what else other than anticoagulation are you going to, and steroid, you're going to give steroid anyway in the pre-phase, which is part of the COVID that you're going to cover, or antimicrobial. So I'm not sure if you're pointing to the anticoagulation specifically.
I think what I mean, would you go for a patient with moderate or mild manifestation to give a full treatment? Because as you know that it's a highly aggressive disease, rapidly proliferating. So would you consider just reduced or give just steroids? I don't know what is the best management of how to handle those patients from your experience.
I can step in.
Pointed that out actually when he mentioned that you can repeat the pre. So I don't know if Dr. Ala wants to comment on that, because if you repeat the pre-phase, then you give yourself time. Dr. Ala.
I used to have a theory from at the very early time when we started to have an outbreak, and it started in Egypt in March 2020, and I had a theory that our patients are mostly immunocompromised. They are vulnerable to COVID exactly in the same way like H1N1. So COVID is not going to be much different than any other viral infection or virulent viral infection. And actually, from the past year and our experience, I didn't see much harm from COVID in our pediatric oncology patients, and we're having a decent number, and Mahmoud is going to be the first author on a paper stating our experience with COVID, and we included in that paper like 76 positive patients documented by PCR. We didn't find that chemotherapy, on the contrary, I believe that if you're postponing chemotherapy, you might end up badly. So, of course, if you're having a very critically ill patient that is directly related to the COVID, you cannot. You buy time and you postpone, and we're trying to give steroid and an anticoagulant, and I should say remdesivir, because we were interested much more in clearing the virus. and I don't say that it's highly recommended, but we're doing it for our immunocompromised patients only. But for those who needed induction and for those who were in a good shape, we loaded them, and believe me, they responded almost in the same way. So this is our experience, and I don't know whether you're having the same experience.
We have to close the session, so I ask Professor Ala to thank the speakers and the chairpersons. So go ahead, Ala, to close the session. Thank you.
I enjoyed the session. Thank you very much, Mohsen. Thank you all for your presence, and I enjoyed the meeting, and not to mention I enjoyed seeing Sharif and Ashraf. It's very good to have you, and thank you very much. Thank you.
Thank you.
Thank you, Dr. Ale.
Thanks. Bye.
Have time to keep with us with Professor Azza Tantawi. Professor Azza Tantawi is the professor of pediatrics and pediatric hematology oncology. She is a consultant hemophilia caregiver. She has a lot of publications in all aspects of hematology, and hemophilia is a main interest. She published with me 20 years ago the low dose ITI. She has quality of life, a lot of publications. She will address very important topic of hemophilia B, a challenging rare disease. Professor Azza, go ahead. Thank you very much.
Thanks a lot, Professor Mohsen Al-Alfi, and congratulations for this always very successful Congress. I'm going to discuss hemophilia B as a rare disease. Let's see. We know all hemophilia B, or factor IX deficiency, or Christmas disease, is an X-linked recessive disorder caused by missing or defective factor IX coagulant activity. Factor IX is very important in the intrinsic coagulation cascade. It's activated by activated factor 11 and activated factor 7, and it activates factor 10 to go on through the common pathway. This is the World Federation of Hemophilia, the annual global survey, 1999-2018. As you see that in 2018, the hemophilia A and B were about 210,000 patients, with an increase of 200% in the number of people with bleeding disorders identified since 1999. Hemophilia A is more common than hemophilia B. It represents 80 to 85% of total hemophilia population, and the prevalence is 1 in every 5,000 male live birth, compared to hemophilia B, which is 1 in every 30,000 male live birth. In Egypt, in 2018, the Egyptian Society of Hemophilia have registered almost more than 6,000 patients with hemophilia, with about 80% hemophilia A and about 20% being hemophilia B. I'm going to discuss this because hemophilias in general, they have been recognized by the FDA and by the European agent EMA as rare diseases. What are rare diseases? Rare diseases are defined as they have specific criteria, and these criteria by the drug regulatory agencies to develop rare disease therapies. The aim is that rare diseases, it's important to give them the most importance to get new drugs for these diseases known as orphan drugs, al-amrad al-yatima, because no one used to care about these rare diseases. In United States, it is defined as a disease that affects fewer than 200,000 people. In the European Union, it is defined as a disease that affects less than 1 in 2,000 people. So these are the orphan diseases. 80% of the rare diseases are of genetic origin, including the hemophilias. In total, the rare diseases are about 7,000, with a range from 5,000 to 8,000. What's peculiar about rare diseases and what's peculiar about our hemophilias as rare diseases, that most clinicians are unlikely to have experience with recognizing or managing majority of these diseases. Diagnosis is often delayed or wrong and optimal clinical management is seldom achieved. Multi-center collaboration and registries are important to study the natural history and management of these diseases, and medical and society awareness are needed. This is for all rare diseases, and it's important for the hemophilias. What about hemophilia A and B, similarities and differences? Concerning the severity of untreated hemophilia A or B, it's based upon the factor level. If it is less than 1%, it is severe. 1 to 5, it's moderate. More than 5 to 40, it is a mild disease. And usually patients with severe, they will bleed spontaneously. The moderate, they will bleed with mild injuries, surgery, or tooth extractions. The mild, usually they don't bleed spontaneously. They will bleed after excessive or prolonged bleeding after major injuries, surgery, or tooth extractions. And this occurs usually often later in life. When you should look that this patient is having hemophilia, if he is having any clinical features like hemarthrosis, deep muscle hematomas, intracranial bleeding, neonatal cephal hematomas, or intracranial bleeding, prolonged oozing or renewal of bleeding after any procedure involving tooth, mouth injury, or circumcision, if there is prolonged or delayed bleeding or poor wound healing following surgery or trauma, unexplained GIT or urinary tract bleeding, heavy menstrual bleeding, prolonged nasal bleeds, or excessive bruising. If you find any of these findings, even if they are not severe, go to the laboratory findings. Presence of normal platelet count, prolonged PTT, it is present in severe and moderate hemophilia B. However, in mild hemophilia B, you may get a normal or mildly prolonged PTT. And in all cases, the prothrombin time is normal. So hemophilia B is diagnosed by a decreased factor IX clotting activity. Activity, not the antigen. This is very important. The normal range of factor IX activity is 50% to 150%. Usually individuals with factor IX more than 40%, they usually do not bleed. However, some increased bleeding can occur in with low normal factor IX in hemophilia B carrier females. And when you are going to go to molecular genetic testing, you may need this for prediction of the clinical phenotype and to allow family studies and genetic counseling. What about female hemophilia B heterozygote females? Factor IX clotting activity is an unreliable test to detect heterozygous females. You should go to the molecular study. However, 30% of heterozygous females have a factor IX clotting activity below 40%. And even those who have a factor level between 30 and 60%, bleeding symptoms have been reported in them. So even in the low normal factor IX level, these carriers might bleed. It's important to look when you get a low factor IX activity. Apart from factor IX deficiency. I thought it was very rare. It's extremely very rare, but I was faced with one of these patients, combined vitamin K dependent factor deficiency, autosomal recessive, defective prothrombin, factor 7, 9, 10, protein C and protein S. They have PT and PTT prolonged, and diagnosis is molecular. But also you may get the defective factor 9 in vitamin K dependent factors deficiency occurring in warfarin, patients on liver disease, patients with different illnesses. But in these conditions, usually the clinical picture will be apparent, and the drug history, you can identify that, as well as a prolonged PT and PTT. So what are the complications of untreated severe hemophilia B? Intracranial hemorrhage is the leading cause of death, and chronic joint disease is the major cause of disability. It's exactly like in patients with hemophilia A, ending in end-stage arthritis if it's not given the proper factor IX. What are the similarities and differences between hemophilia A and B? I'm going to go rapidly to the genetic similarities. If you are going to look to this, the genetic similarities, the factor A genes in hemophilia A, in hemophilia A, you will find this intron 22, okay, and the nonsense mutations, okay, which are considered null mutations, are more common than in hemophilia B, where the majority are missense mutations. missense mutations are among the non-null mutations. What's the value of this? The value of this that is, as many reports now speak about, hemophilia B is clinically less severe than the hemophilia A. Why it is less severe than the hemophilia A? They found that the concept that patients with hemophilia B, they have a less severe bleeding frequency, factor consumption, clinical scores, need for orthopedic surgery compared to hemophilia A patients with this same plasma level of the coagulant factor. Why this is present? They did not find a difference in the associated prothrombotic abnormalities, but they found that these factors could be resulting from that the null mutations are prevalent in severe hemophilia A, 80%, whereas the missense mutations, which are the non-null mutations, are prevalent in severe hemophilia B, constituting about 60%. And the presence of non-null mutations causes the presence of factor IX protein, which could provide some hemostatic protection. And also there are rarer promoter mutations that can spontaneously improve over time. This is called hemophilia B-Leiden. Hemophilia B-Leiden is was described in 1982. There is low factor IX levels until puberty, and then a rise of 5% per year up to a maximum about 60 years. If you look to this, this figure, sorry, I cannot work the annotation, it will disturb everything. Normally with age, the factor IX level increases with age. In patients with the hemophilia B-Leiden, they have a point mutation in the factor IX promoter region, which also contains a binding site for hepatocyte nuclear factor 4, a transcription factor for the steroid hormone receptor superfamily. And by the time of puberty, the increase in testosterone was found to be associated with an increase in the factor IX levels, as you see in the graph, in the lower values. Okay, so there is another factor which is important concerning why it is less severe. It's related to the distribution of the factor IX. Factor IX can distribute in the extravascular space and bind to collagen 4. So this provides a mechanism for undetectable localized hemostatic function, while factor VIII resides exclusively in the intravascular space, and its residence time is determined exclusively by the rate of the plasma clearance. And this explains why the factor IX has extended level of biologically active factor IX. And this puts limits in detecting residual amount of factor IX distributed extravascularly and the pharmacodynamic. And when you are going to calculate the factor IX, which is present at this patient as 1%, you are calculating, for example, the 1% present in the intravascular, but the amount which is present extravascular is almost 3 times that amount. So this could limit the detection of the, or the value of the factor IX when it is estimated. Always estimate the extravascular distribution. What are the differences inhibitors between hemophilia A and B? I have put this as to be in short. Factor VIII inhibitors, they develop about in 30% of severe patients. 50% have a high titer. Infusion reactions are uncommon. Success rate with immune tolerance is about 75%, and immune tolerance is not complicated by nephrosis. However, in factor IX inhibitors, they develop in less than 5% of severe patients. 80% are high titer. They result in infusion reactions like anaphylaxis, angioedema, and may require desensitization, steroids, or diphenhydramine. The immune tolerance success is about 25%, it's much less, and immune tolerance may be complicated by nephrosis, secondary to membranous glomerulonephritis. There could be edema, decreased albumin, proteinuria, and reactions may preclude use of any product containing factor IX. So if this patient is having prophylaxis to factor IX, never use factor IX, whether recombinant or plasma-derived, or the activated prothrombin complex concentrate, which contains factor IX. So what are the management challenges and strategies? According to the WHO model list of essential medicines, 21st list in 2019, they said among the essential medicines are coagulation factor VIII and factor IX. What are you going to do with acute bleeding events? Intravenous infusion of plasma-derived or recombinant factor IX for bleeding events should be initiated even if just suspected hemorrhage, not proved, within 1 hour of noticing symptoms. Recombinant factor IX is the preferred source of replacement therapy, according to the availability. It should be told so. The factor IX activity level should be corrected to 100% of normal for potentially serious hemorrhages like CNS, trauma-related GIT, genitourinary epistaxis, or 30 to 50% for normal or minor hemorrhages like hemarthrosis, oral mucosa, and muscular. And in the presence of inhibitor, each international unit of plasma-derived or recombinant standard half-life factor IX per kg infused IV will raise the plasma factor IX level by 1 international unit per DL, and the half-life is 18 to 24 hours. And the dose usually is given according to the severity of hemorrhage and the site of hemorrhage. What the World Federation of Hemophilia guidelines say, that for treatment of factor IX in patients with hemophilia, it recommends a product containing only factor IX rather than the prothrombin complex concentrate, because it also contains other clotting factors such as 2, 7, and 10, and some of which may become activated and increase the susceptibility to thromboembolic complications. Also, they suggest that if you don't have the factor IX concentrates, you can use fresh frozen plasma, but the solvent detergent fresh frozen plasma. But what's the problem? It is generally difficult to achieve factor IX levels above 25 with fresh frozen plasma alone because of the volume. Usually, if you don't have other possibilities, you can start with 15 to 20 ml per kg is acceptable till you can manage. But if a patient, hemophilia B, is having inhibitor, the only option for treatment of acute bleeding is recombinant activated factor VII, never the activated prothrombin complex concentrates. The use of supportive tranexamic acid or epsilon aminocaproic acid are recommended by the World Federation of Hemophilia. What about prophylaxis in hemophilia B? All of us, we know that. We have the continuous and we have the intermittent prophylaxis, and everyone is having a different aim. With the primary prophylaxis, regular continuous treatment in the absence of an osteochondral disease before the second clinically evident joint bleed and before the age of 3 years, with the aim of near normal musculoskeletal and psychosocial development. Secondary prophylaxis, it is regular continuous before any osteochondral destruction after the second joint bleed, and you want to keep minimal musculoskeletal disease. The tertiary, when you already have an osteochondral joint affection and your aim is to improve normal activities and daily life, but the intermittent, which is given less 45 weeks in the year or less, your aim is just to improve the target joints. On-demand treatment is just to decrease the pain and serious bleeding. It has no other value. The World Federation of Hemophilia strongly recommends to put hemophilia B patients on prophylaxis, severe phenotype. Severe phenotype means severe hemophilia B and the moderately severe having a severe phenotype. And prophylaxis should be individualized, and if the patient is not responding, we can increase the dose or the frequency. And in countries with significant healthcare constraints, the World Federation of Hemophilia still advocates using prophylaxis over episodic therapy. And there are different protocols according to the availability. In Egypt, the factor IX product, this is the list of the factor IX products which are present worldwide, plasma-derived or recombinant, standard acting or long-acting. In Egypt, the available is the Benefix, which is the Nonacog alpha. And this is the pamphlet of the Nonacog alpha, specially stressing on the safety of the drug. And the monitoring, you can use the factor IX level by the one-stage clotting assay. And they have put recommendations, which is mostly they are in accordance with the World Federation of Hemophilia recommendations for the bleeding according to the severity and for the different surgeries. And it proved to be safe in different clinical trials. Dosing for prophylaxis in previously treated patients, and in clinical trials, it was 40, range from 13 to 78 at intervals of 3 to 4 days. So it can be given twice a week. But in younger patients, especially, you may need shorter dose intervals and or higher doses. It is given intravenous, reconstituted in sterile 0.234 sodium chloride. By slow infusion rate, it's important, and given by continuous infusion is not recommended for this product benefits. The producers, they don't recommend. Given slowly, please. Why? Because you are afraid of the allergic reactions. Benefits can be given in all the ages by experienced physician, dose and duration according to the bleeding or the surgery. Patient, it should be individualized. And during treatment, a proper determination of factor IX levels, as we said, monitoring is important to be done. Safety informations. Inhibitors are uncommon event in previously treated patients receiving factor IX containing products. As we said, it's less than 5%. It will manifest as insufficient response. In such cases, it's important, let the patient in a specified hemophilia center. If the patient develops hypersensitivity, check for inhibitors development. Thrombosis and cardiovascular events, they are still a potential risk in patients having factor IX replacement therapy. These therapeutic indications and pathology are very important. Safety and efficacy of benefits for immune tolerance induction has not been established. Sufficient data have not been obtained from clinical studies for treatment in previously untreated patients. No interactions of benefits with other medicinal products have been reported. It's used during pregnancy and breastfeeding only if clearly indicated. No symptoms of overdose have been reported. Contraindications, sure hypersensitivity and non-allergic reactions. Very common adverse reactions are headache, cough, and pyrexia, while common are the hypersensitivity, dizziness, phlebitis, flushing, vomiting, nausea, rash, urticaria, chest discomfort, infusion site reaction, and infusion site pain. Hemophilia gene therapy. Gene therapy is an opportunity for hemophilia patients. This is the last slide, Dr. Mohsen.
Okay.
Gene therapy is an opportunity for hemophilia patient for one-time treatment, to have a lasting factor levels for years or decades. Adenovirus associated or adenovirus vector mediated gene transfer in hemophilia A and B has entered the phase 3 clinical trial. They entered a long way in the phase 3 clinical trial. It's expected that the first factor 8 or factor 9 gene therapy products will soon be approved and distributed in major markets. I don't think before 2 years or more. The problem is global access because gene therapy will be very expensive. Conclusions, hemophilia B is a rare disease, but it is not a rare bleeding disorder. Awareness and registries are needed for early diagnosis and management, and to understand the natural history and the genotype-phenotype pattern. Prophylaxis with factor replacement in hemophilia B should be adopted. It has been found that prophylaxis dramatically lowers bleeding rates 83 to 91% in clinical trials compared with on-demand treatment. And thank you very much. I hope I made you think hemophilia B is important. No number of patients is not great, but they will very much benefit from the prophylactic therapy. Thank you very much.
Thank you, Professor Azza. Top quality presentation. Thank you very much. It is very comprehensive. And I would like to conclude the day. We have COVID session, 6 speakers. It was very up to date. Then we have in the afternoon the Sherlock Holmes non-Hodgkin lymphoma, and now we have the hemophilia B up to date. Gene therapy is the most expensive. I think for a long time is $1.5 million per patient, yes. And I believe it will be not in the near future to be available, at least for Egyptians, yes. But the benefits and factor 9 are available, and I hope hemophilia B patients will be put on prophylaxis. I would like to announce for tomorrow, we'll start at 10 a.m. So please take early breakfast. Join us with the same link. We'll start with Professor Fatma Sliman, Professor Amira, myself, Antonio Piga, Professor Wafa. Then we go for Friday prayer. So sleep well, awake early, have early breakfast. And I would like to thank Professor Azza Abdelgawad again, all the speakers, all the chairpersons. Special thanks for Dr. Khadija El-Tumbari, for Muhammad Gafi, for Professor Amira, all pediatric hematology oncology team, and of course Ahmed Fathi, the secretary of the Espho, for wonderful work. All the board members, Professor Galila, Professor Azza, Professor Ahmed Mansour, Badri Likyabi, Ala Haddad, all the board members, and I thank all the attendees up till now, almost 100. Thank you, Professor Galila, for your time, for your support all the time. We conclude.
أقول لكم بس تصبحوا على خير. Thank you, Aziz. Thank you so much.
يا عزة، يا خديجة، ميرسي لكم كلكم.
Thank you so much.
Thank you. Could I have a photo before we leave? Okay. Smile. Thank you. Bye. See you tomorrow morning, early morning. Bye.